It should up. It just started. So thank you so much. And everyone, I'm going to turn it over to Bailey.
Everyone, my name is Bailey Dimke. I'm a nurse practitioner. I work with Dr. Golasorki and Dr. Lundgren at the Comprehensive Breast Clinic at BayCare in Clearwater. I have been a nurse practitioner for a little over 5 years, and I've been with BayCare for about 2 years now. But I am very lucky to be giving this talk today. And if anybody has any questions, please feel free to ask. I know we're going to have an information section, question and answer section at the end, but I'm happy to answer anything that you guys might have as questions wise. But I'm going to go ahead and get started. All right, so basically, just to start out, I think it's important to discuss what breast cancer is. So breast cancer is a group of diseases in which cells in a person's breast tissue change and divide uncontrolled, likely resulting in a mass or lump. So most breast cancers start in the tubes, also called the ducts, or the milk glands, also called the lobules of the breast. So these are typically what we discuss as far as when we're looking at breast cancers. Breast cancer is a very general term, as there is many other subcategories within what breast cancer really means. So this is just kind of the general definition of what breast cancer is. So what we do know, so there is an estimated, I don't have anything for 2024 quite yet, but what we know is there was about 300,000 cases of breast cancer in 2023. In Florida, there was about 22,700 cases. And in those new cases, it was 850 new cases of invasive breast cancer in 2022, and 43,250 women unfortunately passed of breast cancer in 2022. And then the subcategory, what we called stage 0 breast cancer, which is ductal carcinoma in situ, we had about 51,000 women who were diagnosed with that in 2023. And then as far as men are concerned, because we also include men in our breast cancer talks, is we had 12,710 new cases of breast cancer in men and 530 deaths in men as well too. There are more than 4 million people, or more than 4 million women at this point, who have a history of breast cancer who are alive today on January 1st, 2022. And that number just continues to improve as we continue to have no more data and more research and have more screening with patients. Unfortunately, 1 in 8 women will be diagnosed with breast cancer sometime in their lifetime, and 1 in 39 women will die of breast cancer. So as we can see, over time, breast cancer death rates have gone down significantly from the 1930s. This is mostly due to the importance of screening. And so that's why we're so important to focus on the importance of screening for breast cancer. So, breast cancer is predominantly a diagnosis of older women. Unfortunately, that has been changing over the last several years. But typically, we do see most breast cancers in that 60 to 70 plus age range. We are seeing more early stages of breast cancer, unfortunately, and as young as, I had my youngest patient, it was 19. But, I would say that's not necessarily the norm. Most of our breast cancer patients are typically usually 60 and older. And then as by race, unfortunately, it is pretty much across the spectrum. We have pretty even numbers. Non-Hispanic whites, we do see the most breast cancer diagnoses, followed by non-Hispanic blacks. But at the same time, too, we have to also remember too where we are with screening and access to screening too. So these numbers are probably very generalized across race, because I do think that breast cancer does hit women of all races. And so we're definitely seeing some differences in incidence, but I would say it's pretty even across races. And then deaths by rates, unfortunately, due to screening being usually delayed or finding cancers later on, non-Hispanic blacks are the most affected by this, followed by American Indians and Alaska Natives. As far as survival is concerned, we are really doing a lot better than where we have been in the past. So as far as all stages combined, that would be from stage 0 to stage 4. We have about a 5-year survival rate of 91%, which is really amazing. So that means that of 91%, 91 out of 100 women are basically surviving their breast cancer diagnoses, which is a wonderful thing. When I talk about localized breast cancers, those are breast cancers that are only within the breast. So about 99% of those breast cancer patients are surviving at the 5-year mark. And then as far as regional, what I mean is breast cancer that has gone to the lymph nodes as well too. Those are about 86% of those patients are still living at that 5-year mark. And then we talk about distance, we're talking about people who have metastatic breast cancer that has traveled outside of the breast and the lymph nodes, and we're looking more at 30%. So not looking as great there, but what I would say is I think when we get some updated information from the American Cancer Society, that number out of any of those numbers will actually look significantly better than where we were in 2018. We've gotten a lot of new research and a lot of new drugs that have come down the pike as far as for not only our early stage, but metastatic breast cancer patients. So we've been able to take a lot better care of them. All right. So I think most importantly, what I always think in this particular group to talk about is what are we looking for as far as risks for breast cancer? You know, everyone wants to talk about, checking every month, which I think is really, really important. But there's so many lifestyle things that can be a part of what causes breast cancer. Alcohol consumption is one of our biggest ones that is not mentioned often. Obesity as well too. We actually harbor a lot of our estrogen and within our fat cells. Not having children or breastfeeding, taking birth control pills for a significant period of time, hormone replacement therapy. I think that's kind of in the last few years, a little bit less so than it was we thought so in the past because hormone replacement therapy has gotten a lot safer in the last several years, but still does pose a risk. Family history is always going to be a huge risk factor as far as breast cancer is concerned. Genetics, meaning like mutations such as like BRCA1, BRCA2, and several others. And then having early menstruation before the age of 11 or late menopause after the age of 55. Those are where we're seeing a lot of a risk for breast cancer. So people always ask me, what are the signs and symptoms of breast cancer and what should they be looking for? The scariest part is that most breast cancers have no symptoms, and they're found on screening mammography, which is again why the importance of preaching doing your screening mammography as your doctor prescribes. Most commonly, if you do have a symptom, though, it's going to be a painless lump. Everybody thinks, breast pain is going to be a big symptom of breast cancer when it typically is not. The lump is the most common symptom. Then followed by some other less common ones would be swelling, sometimes redness of the skin, some thickening of the nipple areola complex, spontaneous nipple discharge, especially if it's bloody looking, or other nipple changes like such as inversion or scaling. I always tell people that if you do notice something different, please tell either your gynecologist or your primary care so they can work it up further. And so as far as imaging, people ask me a lot, like what types of imaging is the best way to go about. I see a lot of patients in the high risk setting, so people who are at higher risk for breast cancer. And so gold standard to this point is still screening mammography. Screening mammography catches most breast cancers that we have. If you were to have a screening mammography first and there was something of concern, you would later go for a diagnostic mammogram, which is just typically a lot more images. And they do a little bit more with contrast enhanced. They use a lot of computer technology, AI specifically, that helps them look at more tissues of the breast with a diagnostic. But that is still 100% the gold standard. Followed by that, we would always do an ultrasound as well too, because that's the best way for us to sometimes look at a mass in addition to having the mammogram. And then additionally, what the third way we really look at breast tissues through is a breast MRI. That is typically only used for patients who are at very high risk for breast cancer, or if we already know you have a breast cancer diagnosis, then we would do a breast MRI to basically see what the extent of the disease is. Unfortunately, thermography is a common thing I get brought up with all the time, and patients ask me all the time how, can I do thermography instead? I've done a lot of research on thermography, and although it has its place, it really doesn't have its place in the breast setting, at least not yet. So we are really still preaching doing your screening mammography as your provider prescribes it. All right. So recently, this is like basically hot off the press, the U.S. Preventative Task Force for Women at Average Risk have talked about doing mammograms starting at the age of 40 to the age of 74 every other year. So I know people typically, I recommend still doing a mammogram every year. I think most gynecologists feel a little bit more comfortable with that. That's what the American Cancer Society and the National Comprehensive Cancer Network recommend, is doing an annual screening mammography. But the big news is that we have that new recommendation from the United States Preventive Task Force, which previously that is not what they were recommending. So we are very happy to have gotten that recommendation. It's a huge step for all of us as far as picking up a lot more cancers. As far as women over the age of 75, I would say there's currently insufficient evidence. What I tell people is I think that's basically how you are living. If you think that you have a good quality of life and that you would do something about a breast cancer diagnosis, you should 100% be still doing your annual mammograms over the age of 75. If there's other comorbidities or other health issues that are, kind of trumping that kind of breast cancer diagnosis, or something like you couldn't undergo surgery or you wouldn't want to do any kind of surgery, then I think at that point, that's a reasonable option to avoid the annual mammogram. However, if you're still in good health and if you were told you had a breast cancer diagnosis, I would still want you to continue doing your annual mammograms. I think that's really, really important, because I think that sometimes advocating for yourself is something that is hard. And I think some providers who, they look at the current guidelines and say, hey, over 75, we're not really sure what the benefits and risks are. But if you feel that, you are in good health and you would want to do something, if you have that information, I always advocate for people to push to get their annual screenings done. And typically we don't have pushback from insurance for those kind of things. And then for women who have very dense breast tissue, so we look at breast tissue from a category from A to D. And then that's women who have mostly fatty tissue of the breast. And then we go to the extreme of having extremely dense tissue, which is really hard to look at on a mammogram. We will look at augmenting an annual mammogram with a breast MRI, but currently the evidence is still kind of hit or miss on that. I would say American Cancer Society and National Comprehensive Cancer Network are advocating for that, especially for women who are high risk. All right, so when we talk about breast cancers, this gets a little bit more into the specifics. There is that non-invasive breast cancer, which is called DCIS. That is actually was contained within the ducts of the breast. So I guess I can't really, let's see if I can point my fingers here on my little cursor. This is a duct of a breast. This is where the breast cancer would actually start, is actually right here. These are the tips where the lobules are. LCIS, which is called lobular carcinoma in situ, is actually not considered a breast cancer anymore, more of a high-risk lesion. But when we look at if a breast cancer starts in the duct and has not invaded outside of this area of the duct, that's called DCIS, so stage 0 breast cancer. And then once breast cancer escapes right outside of that duct area and is going more invasive into that area here, or along any of these areas, that's when we look at it as breast cancer is becoming infiltrating or invasive. Like I said, we could have the ductal type or the lobule. So lobules where it would be starting more back here. Ducts is where it would be starting more along the lines here. Ductal is far more common than lobular is. And then we also have the last type, which is the most rare, is inflammatory breast cancer, which actually starts more so in the skin of the breast. When we look at breast cancers that are inflammatory breast cancer based, we're more seeing like skin changes that are of concern. So like bright red breasts, it almost can look like the peel of an orange is also what we kind of have it look like as far as texturing. Thickened skin. Those are typically the symptoms we're looking at as far as an inflammatory breast cancer. Very much the most rare type of breast cancer. We don't see it very often. It's definitely one of those ones that, something that we get more concerned about when we do see it. Unfortunately, we do see it, but at the same time too, it's far less common than the other 3 types are. Right. So then when we're talking about, I always refer to this as the Angelina Jolie genes, BRCA2 and BRCA1. Most people do not have these gene mutations. About 5 to 10% of our breast cancer patients do have the gene mutation. And there is an 87% chance of having breast cancer if you have one of these mutations. Also, if you have a 44% chance of having ovarian cancer by the age of 70. But what I also tell people too is just because you have a gene mutation is not a 100% risk. That's why we have 13% and greater than 50% of people not having those cancers. But it's really important to catch those things more earlier so we can do high risk screening for those patients. So I know that we're really working towards getting more universal genetic testing. That has been a goal for the last 15 years, 20 years. We are not quite there yet, but I do think, looking into like 2030, 2040, I do think universal genetic testing will become even more available to everybody. And genetic testing, the cost of genetic testing has significantly gone down in the last 10 years. I think average cost now is about $250 if in your insurance does not cover it. But back in the day, it was tens of thousands of dollars. There is an increased risk of second breast cancer in either breast with the BRCA1 or BRCA2 gene mutation. And then in that kind of setting, when we talk about the gene mutations, we usually are recommending or at least considering having the conversation of having that either bilateral mastectomy or having a prophylactic mastectomy if we know before you have a cancer diagnosis, and also having your ovaries removed. I think, as far as more time has gone on, that ovary removal portion of this for these BRCA patients has become even more important because we don't have great screening modalities for the prevention of ovarian cancer, at least not yet. And then some other gene mutations that typically are not talked about in the more general population are the ones I have listed here. ATM is typically the one that we're noticing the most. We see that most commonly. There's a 20 to 30% risk of breast cancer. BARDS1, and then the CDH1, as well as the CHEK2 Lynch syndrome, which has all those included, as well as NF1, PALB2, PTEN, RAD51C, RAD51D, STK11, and TP53. These would so whenever we do any kind of genetic testing, all of these breast cancer genes are checked. And in most genetic testing that's available now, all of these would be included in a regular typical genetic testing results. Back in the day, they would be checking like a BRCA1 or BRCA2. We've really gotten away from that because why check two genes when we can check a whole slew? Typically, when we run cancer genetics, we run about 47 genes. So there's a bunch of other genes that we also take a look at, but these are the ones that are breast cancer specific. And we would institute high risk screening with these patients and have them come follow up with our office if they had these genetic mutations. So as far as breast cancer treatments are concerned, I think everybody knows about, mastectomies, and I think that's what people think about the most. But, we're actually trying to get a lot more away from removing a woman's breast. Number one, it's hugely life-changing. Number two, it's a big surgery. There's a lot of long-term effects that, come into play from a psychological perspective. So I think now we're doing a lot more what's called these lumpectomies or partial mastectomies, where we remove part of your breast over a mastectomy. Sometimes we have to do a mastectomy just because of extent of disease. And then depending on as far as how far along your breast cancer is, the receptor status, as far as looking, was it hormone driven? Was it driven by a different protein? Would there be consideration for chemotherapy? And then also we consider radiation as well too, especially if you are doing the lumpectomy. We do know that most patients who will have the breast conservation would benefit from having the radiation as well. And that's the same survival benefit as having someone who's had a mastectomy as well too. And for patients that have a breast cancer that is hormone driven, we would offer them endocrine therapy as well too. And so, like I was kind of saying, going a little bit into more detail, these are the different types of breast surgery that we would actually be doing. This is a little bit farther advanced than I think important for this talk. But basically, if you hear the term lumpectomy, partial mastectomy, that means the same thing. An excisional biopsy is typically only done if we don't think that there's a breast cancer diagnosis, because it's just a little bit different type of surgery that we do as far as wanting to make sure we have a certain amount of margin around the breast cancer. And then as far as a mastectomy is concerned, there are different options that we have. It is based off of where your breast cancer is localized within the breast. A simple mastectomy is where we go ahead and just remove the entire breast, just that of itself. Modified radical mastectomy is where we're also going to be removing all of your a large portion of your lymph nodes and a little bit more tissue behind the breast at times. And then skin sparing or nipple sparing is we try and leave as much skin or the nipple, if possible, with the mastectomies as well too, and just remove all of the inside breast tissue. And then as far as what we always typically we're checking lymph nodes as well too, because we know that the first place that typically a breast cancer will travel to is the lymph nodes. So we look at what's called a lymph node biopsy, where only a few lymph nodes are checked. The surgeons do use a special dye at time of surgery to identify which lymph nodes are the best to be checked. And then if you have actual true lymph node involvement at time of surgery that we already are aware of or found out after surgery, you might actually have what's called a lymph node dissection, where more than 10 lymph nodes are typically removed. Back in the day, anybody has in between 35 to 50 lymph nodes in each armpit area. Back in the 1980s, they were really butchering women, unfortunately, and removing anywhere between 25 to all of their lymph nodes. And there would be a really, really high risk for lymphedema, paralysis, terrible, terrible things. Although those risks are still a possibility now, where lymphedema is still something that we are always watching out for. Numbness, a frozen shoulder, or having fluid collection in that side. Those risks have dramatically gone down from where we were before. We have very, very few patients who have this now. Unfortunately, of course, there always is a risk, and there are some people who are more prone to it than others. But I do think it's a lot less common than we've ever had it than before. I'm going to skip over this because I don't think that's as important for you guys to know about. And then sometimes too, we will talk about chemotherapy first. That's typically because the breast cancer is quite large or the receptor status of the breast cancer. And the goal of that is to reduce the size of the cancer so you can have a better surgical outcome. And so, like I was saying in a previous slide, the lumpectomy, if it's done with radiation, has the same survival benefit as somebody who has a mastectomy. A lot of people don't want to do radiation, but what I would say is even where we were 5 years ago with radiation, we have significantly reduced the doses of radiation that we give people. People have far less burning. I think people have a very bad view of what radiation looks like. And I would say most patients tolerate it extremely well at this point as well, too. And like I was saying, if you are hormone receptor positive, if your breast cancer was driven by hormones, we would talk about these drugs that I think some people have known about in the media, which is tamoxifen being the most common. And then for more postmenopausal women, we talk aromatase inhibitors. Unfortunately, the side effects are menopausal symptoms, but I have a lot of patients who don't have any side effects at all. So I always encourage patients to at least try them. So really big caveat of what this whole talk is really about is what can you do at this point if you don't have a breast cancer diagnosis to prevent yourself from getting breast cancer or at least reduce your risk. So focusing on a healthy diet. When I talk about that, I always say basically the perimeter of the grocery store. So fruits, vegetables, whole grains, lean meats, more focusing on fish and chicken. We know that our bodies are not good at processing chemicals, preservatives, and all of the processed foods. We do know that there is risk there, but I do think focusing on more of that outside perimeter of the grocery store, it does make a difference. And then as far as more research has come out, especially within the last 3 or 4 years, is exercise, which is the hardest little bit for my patients to do, I would say. And 30 minutes of cardiovascular fitness 5 times a week, plus weight-bearing exercise. We are seeing significantly that exercise is a huge, huge, huge benefit, not only to prevent breast cancer, but also to reduce the risk for breast cancer to come back in the future. smoking cessation. Yes, of course, smoking is typically associated with lung cancer, but there is definitely an association with breast cancer as well. And then keeping your alcohol intake low. They have found that anybody who's drinking more than 3 to 5 beverages per week, we're seeing increased rates for breast cancer, and maintaining a healthy body weight. So keeping that BMI to be about 25 or less. Okay, and some special considerations for males. If a male is diagnosed with breast cancer, we always recommend genetic testing. It is similar to female counterparts as far as surgery options and chemotherapy options and radiation as well too. Typically, they also would be recommended that endocrine therapy if their hormone receptors were positive as well too. Follow-up imaging is a little bit questionable. I'm still in the camp of still doing diagnostic mammograms. I think that's kind of where we will get more data in the future. Recurrence rates are a little bit different for men versus women, but we typically do still follow them with imaging. Sorry, there you go. Okay, so let's see. Okay, to make sure. So really the biggest new things when we talk about breast cancer is decreased radiation, which is a really big thing. So I think most people hear some horror stories from other people is from who have had breast cancer diagnosis about how bad radiation is. I think we've gotten a lot better at treating it and a lot better at reducing the doses. We're doing a lot less axillary surgery. So those risks for arm issues is and like so lymphedema, paralysis, issues with, movement has significantly gone down. A big focus too is on oncoplastics. So that doesn't necessarily mean reconstruction, but more so trying to make sure that when we do remove breast tissue, that we're not removing, too much to make you look cosmetically deformed. And so basically, we're focusing on trying to maintain what you previously had, so you don't have too much of a cosmetic change. And then we're focusing on de-escalation. So, just checking lymph nodes, just a few of them, so we reduce that risk for lymphedema. Radiation doses have definitely gone down. And there are actually some studies about that stage 0 breast cancer of actually using some cryotherapy, which is an ice therapy. We are not there yet, but there's definitely research to be talking about maybe just possibly avoiding surgery. And then when we talk about margins, taking as little as tissue around the cancer as possible, with having that still benefit and making sure we're taking enough tissue to reduce that risk for recurrence. And so something I always say too that I think is really, really important. I can't tell you how many of my breast cancer patients come and tell me someone in their life says, "Oh, well, you're just going to get a new set of boobs after a breast cancer diagnosis." And I think that's one of the most hurtful things that anybody can hear when they have been told a breast cancer diagnosis. So I always tell people try and be really sensitive to people that we know who have a breast cancer diagnosis and think of yourself too. Um, you know, a simple like I'm here for you. I'm so sorry you're going through this is far better than, being told that, oh, well, you're just going to get a new set of boobs out of the deal. So, because that's definitely not the way most women want to think about it and look at it. And then that's it.
Thank Thank you so much. There's been a bunch of questions, and I've been kind of taking them down and combining them a little
Okay.
bit so that we can kind of get to that. And I think you did a great job. And I think it's important that everyone knows as we start to answer questions that this is meant for informational. Bailey is not here to diagnose anyone.
Absolutely
We
not.
do need to make sure that you go see your physicians so that if you do need some tests and workups, that you are getting them from the appropriate location and that they can check what's specifically for you because everyone is unique. I'm going to start with one of them as the men, since that was there not as much information for them. And I know, men don't typically get a screening mammogram because of the structure of their body. But why aren't they doing some yearly kind of testing for men? Is the number so low, or why is that not there?
So, actually it's interesting is because I've noticed that a lot more insurance companies are starting to offer screening mammograms for males. I actually think Cigna is one of them on a yearly basis. So I do think eventually that could be something that we're doing. I think more so family history is the biggest thing when we look at males. If we know of anybody is like significant on the female side or male side that has a significant family history, a lot of times we will recommend that they do screening mammography. But at this point, about 1% of males have breast cancer. So that number is still too low for there to be a national guideline for a screening modality for males at this point.
So when you're doing that, men, would it be similar to women? They would feel a lump in their,
Yep.
basically their
Yeah,
chest.
most times for men, they actually feel that lump. It's because they have a lot less breast tissue. Most are found with palpating actually a lump more so, or nipple changes as well too.
Okay. Um, what is the percentage around for a breast cancer patient of getting another type of cancer?
So it actually kind of depends on what their treatment choices are. When we look at patients who have done, surgery, radiation, and they've done either chemotherapy or pills, and they look about to anywhere from like 8 to 12% is a recurrence, basically. Having it in the other breast is about 1 to 5%, pretty low for them. But yes, if we do everything that they're supposed to do from like the surgery, the radiation, the pills, if possible, the chemotherapy, it's about 8 to 12%. If we just do surgery, we know that risk is about usually like about 30, 35%.
Okay. I know when I was going through everything and they were telling me sometimes those numbers of the percentages would get you. If you do this, you get this percentage. If you do this, you get that percentage.
Right. And I
Breast,
think too, they're very individualized. They've gotten a lot more individualized too, based off of your actual cancer subtypes. So these are like more generalized, like speaking in the sense of like everyone as a whole, taking all those numbers into account. But we actually can get those numbers a lot lower if we, and those are kind of lifetime risks. If we're looking more at like a 5-year risk, probably around 2 to 3%. But now we're getting to be able to be a lot more personalized. So that's what we know more for a general statement. But for individualized information, we have a lot lower numbers.
what about breast implants? A little bit more about that. Is there anything special that we should be aware of that? Because if you have the implants prior to
Sure.
any
So I'm not
diagnosis.
anti-breast implants by any means. I will say that usually my radiologists have a little bit of harder time looking at breast tissue that has an implant in it. Typically, we are able to, if, a breast cancer is still fairly small, you are most of the time able to keep your implants. There can be some long-term issues if you have to get radiation as well too. But typically what I say, I am not a person who doesn't recommend implants. Does it make it a little bit harder at times? Yes, but we're still recommending pretty much just screening mammography for those people. If they do have dense breast tissue or they have a lot of obscuring, we will sometimes do breast MRIs on them as well too.
We have a bunch of questions about lumps. So to kind of combine them all, people are kind of wondering like, what if you feel a lump and then you go get the testing and it's disappeared, or you feel a lump and it's kind of moved to a different spot as you're doing that. And these lumps that they check them and there's nothing there. What can be happening with that?
So yeah, so a lot of times breast tissue is very lumpy. So sometimes like I know, several years ago I had a lump area that I was really concerned about. And so I ended up going because I'm not quite 40 yet, I got an ultrasound done first. And it was just normal fibroglandular tissue, so normal breast tissue. Breast tissue is inherently clumpy, especially for our younger women. So ages anywhere from like 20 to 45, breast tissue is at its most dense at that time period based off of where we are in childbearing, really. And hormone changes. Hormones change breast tissue so much. So a lot of women will tell me, "Oh, I felt a lump," and I'm like, "Does it go along with your cycle?" A lot of times they do, and they kind of wax and wane with cycles. Those are typically just something that's cyclic, more so like more from like having periods or just hormonal changes. What I try and tell people is if something persists, like it's more of like really hard, something that's hard and is persisting, that's definitely something we 100% what your primary care, your gynecologist wants to know about. Something that kind of wax and wanes, a breast cancer isn't going to wax and wane. There's also a possibility that it could be a cyst, because cysts can come and go. But even still, if you felt like you felt something that was firm or hard, I would, no matter what, want you to go and talk to your provider about that. And even if you come in and it's not there that at that moment, I think most providers at this point are going to say, hey, maybe we don't feel something right now, but let's just check and make sure everything looks okay.
So no matter what type of lump, talk to your physician. The other
Yes,
big
absolutely.
question was a lot of nipple itching, breast itching, pain under the armpit, like where the lymph nodes are. What
Mhm.
are you seeing there, and what is your guidance for them to be the next step?
Yes, so nipple itching, breast pain are one of the biggest things that I see a lot of patients for. Typically, I would say nipple itching is not a symptom of breast cancer. I would need to see something along with it that is typically for me to be concerned about. Typically, when we're seeing itching, it's more so of a skin issue than it is actually a true breast issue. If you're having true pain within the breast, I would ask you to like really look at where you are in your cycle. And if you are postmenopausal, is it all the time? Most times breast pain is not something that is a huge red flag for breast cancer. Most cancers do not cause pain. I will not say that all do not, but generally speaking, most breast cancers do not cause pain. I would say that I still want you to go talk to somebody. I see tons of patients for breast pain. We're still going to go ahead and evaluate it, make sure it's not something of concern. And then once we've gotten that clear evidence that, hey, everything looks okay, then there are some interventions that we can tell you to do outside of that to kind of reduce that breast pain. But typically, breast itching is not something, it's just unfortunately a weird symptom that a lot of women have commonly. I always tell people, like, make sure you're moisturizing your breasts, which sounds really strange. But dry skin is not limited to your arms and legs, it also comes to your breasts as well.
All right. So we had a couple questions about genetics testing too, because everyone is unique, everyone is different. So we're all going to feel and experience things different. So again, you kind of talked about that
Sure.
conversation, talking about things. I just want to kind of reiterate that. And but with the genetic testing, I know on Morton Plant's campus, we do the genetic testing there. In fact, she came and spoke last year. So we do have about genetic testing filmed. But how often, what type, do you have a specific type that you like? And if you were to be genetically tested, would you repeat it again at any point in time?
So typically in this day and age, if you were to get genetic testing done now, we don't need to repeat your genetic testing because every genetic testing company at this point is retesting their own data. And basically, if your genetics had something in it of concern, they'd actually come back to you at a certain point and let you know that they found something different about your genetics. They're constantly rerunning data, getting more snippets, and finding out more and more over time. For people who have had genetic testing before 2012, I would say those are people who would be candidates to repeat genetic testing. If you had, family members who were at very, high risk for BRCA and you'd had genetic testing in 2010, I would say our data is kind of obsolete on that right now. Anything before 2012, we're like, it's at least worth considering to retest. But otherwise, if you've had genetic testing after 2012, 2013, there really is no reason to retest it. We know that that data is pretty valid and is very accurate. As far as an actual genetic testing company, obviously I work with multiple companies and I'm not going to speak to anyone particularly. They're all pretty universally very good. I mean, I don't think like if we're talking like ancestry, that's not considered to be a true genetic testing for mutations. That's more so for something different. But most of the genetic testing companies out there that are advertising are very, very good. And they have pretty much all similar data that they actually all universally are starting to share with one another more so than they were before. So, if you had a true concern that, you had a significant family history of any type of cancer, to be honest, not just breast. We do have two excellent genetic counselors who are welcome to, or who welcome these conversations, and you can get referred from your primary care for having a discussion as far as if you would benefit from genetic testing and just like the long-term implications as far as life insurance and what it means for your family as well too.
I will add the genetic testing, the information on how to contact them in case anyone does want to reach out to them and ask them some
Absolutely.
questions.
And
Um,
they're both excellent resources as well too.
yes. Couple of questions about imaging that we had to go back to that. I know the 3D tomo for the screening mammograms, people talk about having the 3D image. Is that better? Do you feel it's important that people look for that 3D imaging? And why don't we do an MRI first as opposed to a mammogram?
So, like I said, and a mammogram is going to be gold standard for diagnosing breast cancer. We find over 90% of breast cancers are found on screening mammography. So, I think too that most places at this point in the game, I know at least at BayCare, pretty much everybody who's getting a screening mammogram is getting 3D tomo as well with it too. And that's just basically, it's kind of going through each layer of the breast tissue and helps us look at tissue in a different way than just a pure radiologic image. Um, so, and then there also typically is computer assisted devices as well too with most screening modalities. I know at least at BrayCare we have that. Most smaller facilities, I actually really do think when I get outside imaging, most of the time they're doing it as well too. I think, maybe if you lived in a small town with older imaging, that typically they might not have those capacities. But I would say in the Tampa Bay Clearwater area, most places have that imaging option available. As far as breast MRIs are concerned, breast MRIs are great, but they have a really, really high what's called a false positive rate, meaning that they pick up something that is not of cancerous concern that would make someone get a biopsy for absolutely no reason and cause a lot of anxiety, a lot of stress for no reason. So basically what an MRI is checking for what's called enhancement. So basically that's why we gave you the IV contrast. It's called gadolinium. And it's going to light up based off of blood flow. So areas can light up for a variety of reasons. It can't necessarily be something that's cancerous or something necessarily bad. So that's why we don't automatically go to an MRI, because I think that there is a high rate of something being absolutely nothing and causing a tremendous amount of anxiety and making all of us worry for no particular reason. That's why we start out with the mammograms first and sometimes ultrasounds as well too, because I think those are what's tried and true at this point.
That's awesome. I just think people need to be aware. You said in the beginning, 1 in 8 women is
Mhm.
diagnosed with breast cancer. We all know 7 other women. So it's probably someone we know within our circle will be having to deal with this. So to be a supportive person to them, to make sure that you're there and you're being aware of your own health also. I think you gave us a lot of great tips on that. As I said, this is recorded, that you will be able to view it again, as well as you will be getting the follow-up from this, so you can look at the presentation if you don't want to watch the whole recording again. And I will send some